Welcome, everyone, to the 12th CITF seminar series event, How Social Determinants of Health Affected the COVID-19 Pandemic in Canada. My name is Dr. Kate Hankins, and I'll be your moderator today. I am the former co-chair of the COVID-19 Immunity Task Force, and I'm also a professor and interim chair of the Department of Global and Public Health at McGill School of Population and Global Health. Before we get started, I've been asked to share some instructions as we are providing simultaneous translation into French, and we'll have a bilingual question and answer period. Bienvenue à tous et à toutes.
Welcome, everyone, to the 12th CITF Seminar Series event, How Social Determinants of Health Affected the COVID-19 Pandemic in Canada. My name is Dr. Kate Hankins, and I will be your moderator today. Before we get started, I've been asked to share some instructions as we are providing simultaneous interpretation into French, and we will have a bilingual question and answer period.
At the bottom of your Zoom screen, you will see an icon of a globe. Choose off if you are bilingual and you want to only hear the live feed. English attendees, you should select the English option so you can hear the entire event in English. The presentation will be in English, but the question and answer period will be bilingual. Au bas de votre écran Zoom, vous verrez
At the bottom of your Zoom screen, you will see an icon of a globe. Choose off if you are bilingual and want to only hear the live feed. English, French attendees, you should select the French option so you can hear the entire event in French. The presentation will be in English, but the question and answer period will be bilingual.
Sélectionnez votre langue préférée maintenant.
Please choose your language of choice now.
And select your language.
Veuillez choisir votre langue préférée maintenant.
I am speaking to you from my place of work at McGill University, which is located in Montreal, Jojake, in the area of Turtle Island, now known as Canada, on land which has long served as a site of meeting and exchange among Indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. The Kanien'kehá:ka Nation, which is Haudenosaunee, is the traditional custodian of the lands and waters on which Montreal Jojake sits. We acknowledge the colonial origins of Montreal and McGill University and encourage everyone to engage in decolonizing efforts beyond land acknowledgement. We thank the diverse Indigenous peoples whose presence marks this territory on which the peoples of the world now gather. So today we're going to delve into the social determinants of health and how they have affected the COVID-19 pandemic in Canada. So social and economic inequities have contributed to how certain communities in Canada have been more at risk of getting infected with SARS-CoV-2 in the first place, of being hospitalized for COVID-19, and then dying of COVID-19. Now, some of the factors we're going to delve into include income and material deprivation, employment, household and bedroom density, race, ethnicity, and education. Now, just a little bit about the COVID-19 Immunity Task Force and our mandate. We were established in April 2020 by the Government of Canada, and our role was to catalyze, support, fund, and harmonize knowledge on SARS-CoV-2 immunity for federal, provincial, and territorial decision makers to inform their efforts to protect Canadians and minimize the impact of the COVID-19 pandemic. We've had 119 studies going on right across Canada. Many of them have included at-risk communities that have been experiencing the impact of the social determinants of health on their risk of infection disease, and hospitalization. You can see here from this map that we've gone right across the whole country. Now we have a great panel for you today. First of all, we'll start off with Sheila O'Brien, who's the Associate Director, Epidemiology and Surveillance at the Canadian Blood Services. She's also an adjunct professor in the School of Epidemiology and Public Health at the University of Ottawa. She'll be followed by Upton Allen, who is a professor in the Department of Pediatrics and the Institute of Health Policy Management and Evaluation at the University of Toronto. He is the chief of the Division of Infectious Diseases and a senior associate scientist at the Hospital for Sick Children that we generally call Sick Kids. Jack Jebwab is the president and CEO of the Metropolis Institute and the Association for Canadian Studies. And he'll be joined by Simona Bignami, who's a professor in the Department of Demography at the Université de Montréal. And our final speaker will be Sonia Anand, who's a professor of medicine and epidemiology and associate chair equity diversity at the Department of Medicine, McMaster University. She's a vascular medicine specialist at Hamilton Health Sciences and a senior scientist in the Population and Health Research Institute. She'll be joining us a little later. So let's start off with Sheila talking with us about the social determinants of health as seen from the optic of the Canadian Blood Services. Over to you, Sheila.
Well, thank you very much. It's a pleasure to be here. Next slide. I would like to acknowledge that since I am in Ottawa, I am on the traditional unceded territory of the Anishinaabe Nation. Next slide. I have no conflicts of interest. Next slide. And I'd like to start by telling you a little bit about our blood donors. So blood donors are people who are at least 17 years old. There's no upper age limit to donate blood. They will be feeling well on the day that they donate, meet donor eligibility criteria. They are at low risk of blood transmissible infection and not taking certain medications, although many medications are okay. We collect blood in all provinces of Canada except Quebec. Quebec blood supply is managed by Héma-Québec, and we do not collect blood in the territories. We have collection sites in all major cities and most smaller cities and many towns, and that's through a combination of fixed sites and mobile sites. Next slide. So this, the issue of donor representativeness is very important for interpreting the results. So this is a slide that was prepared by the COVID-19 Immunity Task Force from earlier in the pandemic. And what you can see on the right-hand side where it says blood bank, those are, and looking at the black line is the median seropositive percentage of studies that used blood donors to measure seroprevalence. There is the one in the middle is using residual sera, so studies that used a leftover sample from patients. And then the one on the left are purposeful household surveys where they went out to get a representative sample. And you can see that they all produce rather similar seropositive percentages. So we think that even though donors are a healthy population, they are a pretty good representation of what's happening in seroprevalence. Next slide. So we have been testing samples every month since the beginning of the pandemic and have at this point tested over 500,000 donations. Next slide. So nearly all of our donors were vaccinated in 2021. You can see on the right-hand side in the graph, this is the vaccine seroprevalence. The dark green is the oldest donors, so those 60 plus, and their vaccine antibodies increased first, followed progressively by younger age groups, which coincides with the rollout of vaccine. Next slide. So how do we measure social determinants of health? So we at Canadian Blood Services, we ask all of our donors about their race and ethnicity. It's voluntary, but most do answer. And that's done to find donors with rare blood groups to better match blood products to patients. We also used a material deprivation scale. And that is a standardized scale that divides the population into 5 groups based on the neighborhood where they live, and Statistics Canada data on that neighborhood, such as the income, job security, and education of attainment of people. So of course, not everyone living in the neighborhood is the same as everyone else for these things. So it gives a general indicator of socioeconomic status that is probably true for many people in that neighborhood, but not necessarily all of them. Next slide. And this is showing the infection-acquired seroprevalence in racialized groups, so that's the green line, and in white donors, that's the red line. So notice that in mid-2021 on the left-hand side there, that when vaccine rolled out, that racialized groups had higher seroprevalence at that time. And in fact, all the way through the pandemic. So, and in about January to March of 2022, with the onset of the Omicron variant, it actually gets a little bit wider. So with blood donors, we are, you might question, well, what is causing this to be, the seroprevalence to be higher in racialized groups? The shorter answer is that based on these data, you don't know. But what we do know about donors is that it's unlikely to be something such as language barrier, because all of our donors complete their donor screening and consent in English and in French in some areas. It's also unlikely to be distrust or discomfort with medical care because clearly all of these donors are donating for a very important clinical cause. So it's although we do not, so blood donors are a very good population to study because we can, because they're more defined, and some of the more extreme reasons for marginalization will not be present in our blood donors. Next slide. So this is a study that we did on our 2021 data with collaborators from public health across the country, and their names are shown there on the right. And the green bars are the racialized donors, and the red are the white donors. And you can see that infection-acquired seroprevalence was higher in all regions of Canada. And notably that it's higher in Ontario and BC than the differential between in other regions. So we combined all of our racialized donors into one variable for these analyses. But of course, that would include many, many different backgrounds and ethnicities. And that's likely the reason for that difference. Next slide. And this is in the gray line, the higher seroprevalence, infection-acquired seroprevalence is seen in donors who live in the most materially deprived neighborhoods. And in the red, the lower seroprevalence in those who live in the least materially deprived neighborhoods. So you also will notice that the gap between the most and the least is not quite as large as it is for the racialized donors. And it's not clear if that is because material deprivation is a little less of a barrier, or if it's because we're using neighborhood indicators as opposed to a direct question as we have for our racialization. So in terms of material deprivation, it may be that people who live in the materially deprived neighborhoods have do a different type of work, and maybe it's less practical for them to work from home. So having more contact with others as part of their work could be housing density. Next slide. And here we have our 2021 analysis of regional differences. The most deprived are shown in the two red bars, the most materially deprived. And you can see that in all regions except Atlantic, material deprivation is associated with higher infection seroprevalence. So next slide. So our key learnings are that seroprevalence due to infection is higher in racialized donors. It's higher in donors from more materially deprived neighborhoods. And since most of our donors are reasonably health conscious, there is not a language barrier, and they are likely very comfortable with medical care and medical advice. These findings really underscore the pervasiveness of the socioeconomic gradient in Canada. Thank you. And I would like to acknowledge my team at Canadian Blood Services. As you can see, there are many, many people who have worked very hard over the last 3 years on this study.
Thank you, Sheila. I really liked that image that you had on your learning slide, the circle of people holding hands. That was really great. And I think we'll get a bit more into this material deprivation. Yeah, you mentioned a number of factors, the type of work people might have, the amount of crowding, and so on. So I think we'll develop a picture as we go through the seminar about this. For the audience, if you have any questions at all, please put them in the Q&A. Those that can be answered quickly will be answered quickly. The rest will be saved up for us to be able to interact with our speakers today to get some responses at the end. So I'd like to go now to our next speaker, Dr. Upton Allen. He'll be speaking about COVID-19 seroprevalence and vaccine responses among Black Canadians. Upton, take it away.
Thank you very much, Kate. It's a pleasure to be with you. I'm so appreciative of the opportunity to present today. I'd like to begin by acknowledging the land on which my institution, CITF, operates. For thousands of years, it has been the traditional land of the Huron-Wendat and Petun First Nations, the Seneca, and most recently, the Mississaugas of the Credit River. Indeed, Toronto is home to Indigenous peoples from across Turtle Island, and we are very committed to working towards new relationships that include First Nations, Inuit, and Métis people. And we are extremely grateful for the opportunity to share this land in caring for children and their families. Now, if we move to the next slide, I have no conflict of interest related to this study. It was really quite clear to us during the first year of the pandemic, which is the focus of this particular slide, that Ontarians who were living in hot zones, such as the northwest quadrant of the Greater Toronto area, were disproportionately affected by COVID. And we showed that they were more than 3 times likely to have infection-acquired antibodies during year 1, the period prior to vaccine. And as shown in this particular slide, at the extreme right, the red area represents the highest rates in terms of antibody positivity, and left would be the lower rates. And so areas that we studied, such as London, Oakville, had rates less than 5%, as you can see. Whereas the Northwest Quadrant, rates were in the 10 to 20% range, where the highest rates were in individuals less than 20 years of age. Individuals who identified as Black were 14.4%, lower bound of the 95% confidence interval, 9 upper bound, just less than 20. Frontline workers, 13.4%, a slight typo there, and students, 13.0%. Overall, in the Northwest quadrant, we had a seroprevalence rate of just less than 13%, 12.6, as you can see. Now, on the next slide, we've done, as we continued to do this study at different phases, we've divided the periods into four, as you can see. Period one essentially is what I just showed you. And so where are we now in period four, which is period ending December of 2022? And you can see now that most participants by now have infection-acquired antibodies to SARS-CoV-2. And so, for example, we're looking at overall positivity rates now of 55%, as you can see, and the GTA Northwest, which started out in period one overall, 12.6%, now 66%. And other groups, as you can see, we're looking at seropositivity rates of in the mid-60s to low 70s. As we might discuss later on, we believe that these numbers perhaps do represent somewhat of an underestimate, if anything. So if you move to the next slide, one of the questions we had was whether or not individuals who had previously had infection, how were they responding to vaccine? And we had people who would say to us, well, you know, I had COVID, and so I'm going to take only one dose or two doses, and and that is always a challenge that we have to deal with. So we did a really quick preliminary look where the bar on the top shows you the spectrum of antibody levels coming back from the lab. At the low end, you can see we designate that as less than 500 binding antibody units per ml, and the high end, more than 1,500. And we simply wanted to divide the group into two: individuals who are the high end in terms of antibody responses, and individuals who are not at the high end. And essentially what we were able to show is that individuals who previously had evidence of SARS-CoV-2 infection were significantly more likely to be represented in the high end in terms of responses. So obviously, intriguing information, but provides the impetus for further examination of the whole concept of a hybrid immunity. So we move to the next slide. We recognized, as we all are aware, that data had emerged during the early parts of the pandemic that showed that individuals with sickle cell disease were among those who are at highest risk of having severe outcomes from COVID-19. Now, some of this is related to the fact that sickle cell disease is predominantly a disease of Black individuals, but it's more complicated than that. Nonetheless, we wanted to have a closer look at vaccine uptake in this vulnerable population. Were people getting vaccinated, recognizing that there are a number of risk factors that were intersecting potentially to increase the chance that they would have bad outcomes from COVID. We found that more than half of children studied, defined as less than 18 years of age, had evidence of SARS-CoV-2 infection. And what was interesting was that approximately 60% of those who were eligible to receive 2 doses of vaccines had already received 2 doses of vaccines. And this was really good. Numbers could be higher, but certainly was higher than I had feared, given concerns regarding vaccine hesitancy within the population. But what was more distressing is that less than 10% of eligible children, or children who were eligible for a 3rd dose, received a 3rd dose. So they were not going beyond dose 2. Now, if you move to the next slide, when you look at the province of Ontario more generally, you realize, well, this is, it's a more general issue. It's not something that is confined to the sickle cell disease population or a group that has an underlying predisposition to bad outcomes from COVID, but across the province of Ontario, vaccine uptake, i.e. boosters, i.e. beyond those two, was really poor, less than 10%. Now, if you move to the next slide, we also wanted to look at the children with sickle cell disease to see whether or not vaccine was causing any significant adverse events, because families would often be concerned that vaccine might be associated with adverse events. It's not a very, it's a very common situation that we see in situations where individuals have an underlying chronic disease and they're concerned that somehow vaccine is going to make that their underlying disease worse. Overall, side effects are generally mild, pain and discomfort at the injection site, but not much more than that. And we encountered one episode of a sickle cell crisis within a 6-week observation period among the first 175 kids who were vaccinated. So if we move to the next slide, we could not have done this work, and I really can't overemphasize that. We could not have done this work were it not for a community advisory group that we set up. We engaged this group before the research started, made sure that they were plugged into all aspects of the planning and execution of this study. But most important is that we continue to engage them throughout the study. And in fact, we still continue to engage them at the periodic meetings. So this sustained interaction was really important. An advisory group led by leaders of the Black community, including individuals from different socioeconomic strata, and including people who had, boots on the ground, so to speak. We felt this was really important, and people felt a sense of ownership of the work that we're doing. Now, of course, in the next slide, I always worry that I leave off important names, and I have, and I will apologize for doing that. But I just wanted to acknowledge the community advisory group, the Surmar Community Advisory Group, chaired by retired Citizenship Court Judge Pamela Pelt, for the outstanding contributions that they have made to the success of our work so far. And of course, as the next slide showed, we would not be able to do this work without support that we have received so far. So thank you so much.
Thank you so much, Dr. Upton Allen. It's interesting because you were showing the increase in infection levels in terms of antibodies and so on. And in our December monthly newsletter, we were able to estimate that about 25 million Canadians became infected between December 1st, 2021 and October 15th, 2022. And that's what you were seeing. Now, you've brought in the additional factors of youth and race into our conversation today. So thank you so much. We'll move on now to hear about the impact of the social determinants of health on the COVID-19 pandemic from the Montreal perspective. Jacques Jedwab and Simona Bignami are going to present to us now.
Hello, everyone. So I am Simona Bignami, and I am going to continue talking about the COVID hotspots by bringing indeed our perspective from Quebec. So next slide, please. And I just would like to acknowledge that I'm speaking to you from Montreal, also specifically from the Université de Montréal, which is situated where long before the arrival of the French, people of many indigenous nations came together and interacted. And so we wish to acknowledge these nations, their descendants, and the spirit of fraternity that presided over the signing of this 1701 Great Peace of Montreal. a treaty that fosters peaceful relationship between France, its indigenous allies, and the Haudenosaunee Federation. The spirit of fraternity that inspired this treaty serves as a model for our own university community. Next slide, please. We have no conflict of interest to declare related to this study. Next slide, please. So what is Risk Montreal? Risk Montreal, it's a study that we carried out starting in August 2021 that aimed to collect both quantitative and qualitative evidence on both the individual and household risk factors and immunity among the residents of Montréal-Nord and the residents of other Montreal neighborhoods. Why Montréal-Nord? Montréal-Nord has been, since the beginning of the pandemic, the hotspot of COVID-19 in the city of Montreal and in the rest of Quebec. And so exactly to better understand how certain neighborhoods become hotspot for COVID-19, we collected this data attempting to compare down the line COVID-19 risk profiles according to individual beliefs, attitude, and behaviors about the disease, and the sociodemographic characteristic of these individuals and their households, notably age, gender, occupational status, minority immigration status. Next slide, please. So as of the end of December 2022, we have overall interviewed 5,542 participants with our online quantitative survey. Of these, 1,773 have consented to give a dried blood spot sample to a certain natural or vaccine-acquired immunity for SARS-CoV-2. So the results that I'm presenting to you today are for 1,318 participants aged 18 years and older, for which we have both survey responses and results and seroprevalence results. Next slide, please. So of these 1,318 interviewed respondents with available serological results, the majority were women, 70%, and the majority identified as white, 85%. 60% reported to hold a graduate degree or higher, and approximately 3/4 reported to have been born in Canada. Of the 2,100% that were born abroad, only 9% reported to be recent immigrants. What do these results highlight? They highlight the difficulties of actually reaching lower educated and immigrant respondents in our target sample, even in Montreal-Nord, even though our sampling strategy privileged respondents in this neighborhood and in these specific demographic subgroups. Next slide, please. Even in Montreal-Nord, where we were able to interview, as I mentioned, more respondents, but where we have 131 respondents with available serological results, an even higher percentage were women, 77%. The majority identified as white, 81%. A slightly higher percentage than the overall sample reported to a slightly lower percentage than the overall sample reported to hold a graduate degree or higher, about 40%. But the majority still reported to have been born in Canada. So even in our Montreal-Nord sample, our sample composition is skewed towards non-racialized, non-minority groups. Although our sample in Montreal-Nord is as a lower degree of education than the general sample. Next slide, please. So what do we find in terms of seroprevalence in the different subgroups? that we were able to interview in our sample. Here, what I'm presenting to you is just the percent seropositive by each category that it's indicated in the table. It's a very simple cross tab, and we are still working, as I will say later, to actually cross these results further for certain subgroups. Overall, for the whole samples, for all respondents age 18 and plus, the seroprevalence was almost 20%, so it was 19%. Seroprevalence was highest for males, which you may remember represented the smallest percentage in our sample. So it was 20% versus 19% for female. Seroprevalence was also highest for those aged 35 to 54, which represented approximately 50% of our sample and had a seroprevalence of 21%. Respondents who were less educated also had a higher seroprevalence than the other groups, close to 21% for those with a secondary education or less, compared to 5 or 7% for those with higher education. Those respondents who were born in Canada had a higher seroprevalence than those born abroad. According to occupation, we found that teachers, followed by healthcare workers, had a higher seroprevalence than those in other occupation. Interestingly, overall, for the whole sample, and I'm going to get to you in a second what explained this result, respondents in Montreal Nord did not have a higher seroprevalence than those in other neighborhoods. And in fact, respondents in other neighborhoods had a seroprevalence of 20% compared to 15% in Montreal Nord. Now, why is that? Next slide, please. Because time played a key role in influencing all of these results. As I mentioned, our data collection spanned from the beginning of the Omicron COVID wave until the end of fall 2022. And so on the one hand, the global evolution of the pandemic evolved over this time, but that had an influence on our sample participation on the one hand and the seroprevalence that was recorded for those who participated in our study. So if you can see here, and I'm going to start from the bottom of this table this time, respondents in Montreal Nord had actually a much higher seroprevalence than respondents in other neighborhoods post-Omicron. So post-Omicron in Montreal Nord, we had a seroprevalence of 36% compared to 24% in other neighborhoods. And that decreases to 20%, which is still higher than for the other neighborhoods in the fall of 2022. Healthcare workers and teachers, as in the overall sample, remain the occupational group with the highest seroprevalence in all 3 periods. Those born in Canada also remain to have the highest seroprevalence because they represent the largest proportion of our sample throughout the study collection period. And the results for the different educational level vary also over time. So those with secondary education have a slightly higher seroprevalence during the Omicron wave, but then actually have a lower seroprevalence in the following periods of observation. According to age and gender, female are slightly more likely to test positive than men during the Omicron wave, then slightly less likely post-Omicron, and then the results balance out in the fall of 2022. According to age, in the Omicron wave, it's actually those 55 and plus that have the highest seroprevalence, almost double than those 35 to 54. But then it is indeed those who are age 35 to 54 who have the highest seroprevalence, as we observe in the whole sample. And all these differences are statistically significant over time, which means that over time, the difference that we observe according to age, according to gender, according to education, are statistically significant. Whereas what we do find in the whole sample, in the table that I showed you before, is that those differences at one point in time, as the whole period of observation considered together, are not statistically significant. So time plays indeed a key role in our results. Next slide, please. So this is just to highlight the results, and I just highlighted in at the bottom of my table concerning to Montreal Nord. So to reiterate once again that respondents in Montreal Nord, which is our hotspot, were indeed more likely to test positive than respondents in other areas of Montreal, with the exception at the beginning of the Omicron wave. Next slide, please. And so to sum up what these results mean in light of the challenges that we faced, the evolution in the spread of COVID-19 over time and across population subgroups has been a real challenge for us in our data collection. And one of our main next steps, as you will see in a second, is actually to try to disentangle the role that evolving sample composition played for the evolving results with respect to COVID-19 seroprevalence. This evolution over time reflects on the access to testing for COVID-19 and also the attitudes toward testing, which has directly affected our analysis and our interpretation of the data that we have collected. And these evolving attitudes toward testing have also impacted how selected sociodemographic groups have been more or less reticent to take the dried blood test that we were offering with our sample. Next slide, please.
Hang on.
So I give the word to Jack.
Yeah, I'm going to jump in. Can we actually go back to the previous slide in terms of the challenges? So, you know, Simona, thanks Simona very much. And, you know, it's been a very sort of challenging study in the sense of trying to look at the various time periods and situating the evolution of our results across the time periods as the contagion had evolved, as we all know, and attitudes evolved as well as we observed through our own research, both from the survey standpoint and the antibody testing standpoint. We saw changes in that regard as well. I actually also wanted to mention one point before I get into the final slides, and that is that in the results that Simona presented, we do the comparison to Montreal North, which is our target area, and what we call all of Montreal or the rest of Montreal. And what we uncovered in looking more deeply at the data, and we're still looking, still further probing this, is that there are other areas of Montreal where there's sufficient sample size that enables us to actually offer some conclusions that are statistically significant for other areas of Montreal. So by and large, even though we refer to the rest of Montreal, in other areas that I gather many of you are not familiar with if you're not from Quebec or you haven't sort of frequented Montreal for tourist or study reasons, we have pretty robust numbers for Ahuntsic-Cartierville, Côte-des-Neiges, Notre-Dame-de-Grâce, Mercier, Hochelaga, and Rosemont Petit Patrie. So in those areas also, what we need to do is look at the sociodemographics of those particular places where there, I've noticed, at least on first glance, disproportionately higher rates of positivity or seroprevalence in those areas. And so what we need to do is better unpack, which is not what we set out to do at the outset of our study. We're really looking at Montreal North and the rest of Montreal as our sort of sample comparison basis. We are in a position now to mine a bit more deeply for those other parts of Montreal and also try to line up and match up the sociodemographics while considering the evolution of the contagion and you know what happened on that basis. And you know we've divided into the three periods that Simona and I and the team agreed to you know to focus on, but we probably need to look and match against the evolution of what transpired globally over those three periods that we've identified. Now we can go to the next slide. So I decided, sorry, next slide, please, thank you. Just to sort of close with a couple of slides, we're actually trying to get a better handle on the reticence of certain groups to test. And this is in terms of what you're seeing on the screen, results not from our study that is our risk study, but from rather large survey samples from CIHR-funded research that we've been doing in Canada, United States, and Mexico, where basically I've extracted the Montreal portion of it. You can see the sample size at 347. This was done in September, I believe, of 2022. And so we're looking at the previous 6 months. And what you can see for Montreal is that by and large, 61% of people took a rapid test at home. 38% of people did not do so. And pretty consistently across both age groups and gender, there's relatively similar rates of people taking those rapid tests. People 55 and over less likely to do so. You can see in the next sort of set of rows, looking at racialization and immigrant status, people who identified as racialized, 56% took the at-home test compared to 68% who were not this minority. So a 12-point gap there. And similarly for immigrants, a 13-point gap in terms of the degree to which people took those at-home tests over the previous 6 months. You can also see in the bottom slide that those people who are vaccinated are much more likely to take those at-home tests than people who are not vaccinated. We have a lot more data on people who are unvaccinated, which we can share with those people who are interested here by simply sort of reaching out to us by email if that interests you. We're trying to understand a variety of attitudes for people who are not vaccinated. But as you can see, most of our sample was vaccinated in the risk study we've done for CITF. Next. So our conclusions, community of residence, age and occupation status are strongly associated with COVID-19 seroprevalence. We also noticed, as you may have noticed, the high rate of healthcare workers that reported that were seropositive in, I guess, the post-Omicron period. And although the sample size is small, respondents who are male, age 35 to 54, and residents of Montreal North had the highest seroprevalence rate after the Omicron wave. Healthcare workers, as I said, followed by teachers, also had higher rates of seroprevalence. But again, we see the evolution over those 3 periods that we feel needs to be the object of greater attention as we go forward. And as I said, we want to also do more of a breakdown for Montreal, because all of Montreal doesn't take into account those diverse sociodemographics that we probe more deeply in Montreal North. Next. Next steps, as I said, we need to understand how the changing sample composition over time has affected our descriptive results, and that will also involve us looking a bit more deeply at Montreal's diverse demographics and some of the other smaller areas in Montreal. And more in general, we need to understand the interplay between the different sample characteristics and the seroprevalence over time. Again, keeping in mind that we're looking over a larger block of time than I think we might have anticipated. And we have broken it down into 3 parts, but it's something we'll need to study more closely. Finally, next slide. I'd like to acknowledge and thank the COVID-19 Immunology Task Force for providing funding for the Risk Montreal project, as well as our study team, Fatmata Kamara, Paul Hawley, Jeanne Latour, and Sean Goldsman. Thank you so much for all your support, and we look forward to continuing to work with everybody. Merci, et on est prêt à répondre aux questions après.
Thank you. And I just will remind
and we can answer questions afterwards.
Post questions to any of our presenters. You can post them now as things move along. So thank you, Dr. Jedwab and Bignami. And now let's go to hear from Sonia Anand. She's going to present on seropositivity and risk factors for SARS-CoV-2 infection in a South Asian community in Ontario. Sonia, take it away.
Thank you very much, Catherine, and thank you for the invitation to present. And I'm presenting on behalf of the COVID Community South Asian Study and investigators. If we go to the next slide, the land on which I stand at the present time is the traditional territories of the Mississauga and Haudenosaunee Nations, and protected by the Dish with One Spoon Wampum Agreement. Next slide, please. I have no conflicts of interest to declare. Next slide. The rationale for the study, COVID Community South Asian, was first to address an issue that was floating around in the media, that people of South Asian origin which means people who originate from the Indian subcontinent, were affected by SARS-CoV-2 to a greater proportion than non-South Asians. South Asians are an important group in Canada, representing the largest non-white ethnic group and the fastest growing group of new Canadians. In Ontario, where I live and work, the Peel region, which includes the city of Brampton, Mississauga, and other communities, were often featured in the press as being particularly hard hit by the first wave of the COVID pandemic. And when people did indirect analyses, it appeared as though the Peel region was disproportionately affected. And this was a concern because this community is typically represented by newer Canadians who are more likely to be working in essential jobs. And there were a number of community advocacy groups who felt that the Peel region were not getting the resources they need to properly test individuals living there for COVID, as well initially when the vaccines were rolling out, that the Peel region was not prioritized. So we wanted to investigate issues including seroprevalence, vaccine uptake, as well as some of the social factors that may affect both of those two things, along with vaccine confidence. Next slide, please. And here we will see the comparison of the Peel region to the rest of Ontario. So all of Ontario is shown in green, and the Peel region is shown in blue. And you can see in the first, second, and third waves that the Peel region had disproportionately higher number of cases, again, using indirect sources of data from Public Health Ontario. And when I say indirect, many of you will be aware that most of our health administrative data collection sites in Canada do not collect ethnicity. And in the case of Ontario, ethnicity was not collected at the outside of the pandemic, but change was made in the spring of 2021 to start collecting ethnicity, but there was a relative underreporting of that. It was an optional question, and that's another discussion in and of itself. Next slide, please. And in our study, we have recruited South Asian participants in Ontario as well as British Columbia. And what I'll show today just reflects the Ontario component of the study. And to recruit participants into the study, we used multiple methods. The primary source of recruitment was at vaccine centers in the spring of 2021 when vaccines were rolling out. And we also tapped into other networks in which we already had relationships for other types of research, such as diabetes and cardiovascular disease, to also encourage South Asian participants to join this study. And the study first visit included baseline questionnaires about health status, sociodemographic factors. That includes the type of work, the type of household individuals lived within, as well as some questions with respect to vaccine confidence. And then we also asked participants to complete a dried blood spot. And from the dried blood spot information, we generated the seropositivity rate. And we worked with one of the CITF labs under the direction of Marc-André Langlois in Ottawa. You'll see in this first group, again, the Ontario group, recruited into COVID community, that the mean age of the study was about 40 years, about 50% were women, using the accepted classification of essential work. About 33% of our participants performed essential work, in healthcare or factories or transport, such as truck driving, and about 20% reported living in a multi-generational household. Approximately 65% of the South Asians recruited were born in Canada or had lived in Canada for at least 10 years. Next slide, please. And you will be familiar with the dried blood spot methodology to assess seropositivity. And at this first analyses of our participants recruited early on, again, this was early on at the time the vaccines were just beginning to roll out. The approximately May to August recruitment of our South Asian participants yielded a seropositivity of about 24%. And then when we adjusted for correlation of multiple individuals who came from the same household, this reduced slightly to about 23%. So that was at the time pre-Omicron amongst the highest positivity rate reported across the country. I think competing with the study from Quebec and Ontario amongst incarcerated individuals. Next slide, please. So when we looked at factors that were associated with higher seropositivity in our study, taking care to consider the certain biases that may occur with recruiting participants who are at vaccine centers, we observed that men, older individuals with lower levels of education, those living in multi-generational households, those in the lower income regions defined by the forward sortation area, and those who lived in the city of Brampton were more likely to have a higher seropositivity. Next slide, please. Thank you. And here we've mapped out the seropositivity or prevalence rate here on the x-axis by the cumulative incidence per 100,000 on the y-axis. And then we have placed on the particular forward sortation area letter number codes on top of this graph. And you can see the red dots reflect the city of Brampton, which was really the heart of the hotspot of the high rates of COVID-19 infection. This is known to people who live in Southwestern Ontario. I practice in Hamilton, Ontario, which is south of Brampton, and we, from the hospital system, had to admit large numbers of patients from this region when their hospitals became overwhelmed. Next slide, please. When we assessed our participants with questionnaires, we did ask questions with respect to their sources of information throughout the COVID pandemic. There were, again, some comments in the media, or potentially you could say myths about how immigrants received health information. And so we asked the question, and you can see that the top three sources and trusted sources of health information are fairly traditional and likely widespread throughout the population. Trusted sources included healthcare providers or provincial public health bodies, traditional media sources, and social media. And when we drill down more in our qualitative study, we see that there were two advocacy bodies dedicated to increasing awareness within the South Asian population in the Greater Toronto Hamilton area, the South Asian COVID Task Force and the South Asian Health Network. And they took it upon themselves to translate much of the healthcare provider and public health bodies' information and disseminate it they held webinars, and they also had testing centers where the physicians and nurses doing the testing spoke the common South Asian languages. And this likely made a difference in terms of the trust. I will also say that the medical officer of health in this region at that time was Lawrence Lowe, and he was a co-investigator in this study and very quick to partner with these South Asian advocacy networks. And I think that went a long way to increasing resources for COVID testing and vaccination that eventually came to this region. Next slide, please. We asked some questions with respect to vaccine confidence. Some of you may be familiar with the VAC scale. There are a number of scales that have been validated and assess vaccine confidence. And this one had been validated specifically assessing vaccine confidence with respect to COVID-19. It is a 12-item scale. You can see some of the types of questions asked there. And essentially, there are 4 subscales or domain areas that we assess. One is mistrust of the vaccine's benefit. Second, worries about unforeseen future side effects. The third, concerns about commercial profiteering. And finally, an individual's preference for natural immunity. So how we scored this and the data I present, the higher score reflects more vaccine hesitancy. We'll go to the next slide, please. And you can see, first of all, there aren't dramatic differences just on the basis of how we scaled this, but individuals who were younger appeared to be more hesitant from our study sample, no differences by sex, and individuals who were newer immigrants had slightly more hesitancy with respect to getting the vaccine. Next slide, please. You can see here that individuals who had lower levels of education, so less than high school graduation, trades, certificates, or vocational schools, had slightly higher vaccine hesitancy compared to those with higher levels of education. Individuals who were living common law or married had slightly higher vaccine hesitancy. And then with respect to employment, we observed those who were employed had slightly more vaccine hesitancy. The group of unemployed also included individuals who were retired or laid off. Next slide, please. Of course, many of these factors could be correlated. And so we have just done a preliminary multivariate analysis where we put all of those factors together in a multivariate model. And the ones that come out as independently related to vaccine hesitancy includes education, whereby individuals who have higher levels of education have lower vaccine hesitancy. Employment status, meaning those who were employed but not retired, or unemployed, so employed versus the other groups, were more likely to have hesitancy, and immigration status, meaning newer immigrants were more likely to be hesitant toward receiving the vaccine. If we go to the next slide, we'll sum up everything by saying we did observe early in the pandemic a higher seropositivity in the South Asian population compared to other communities. It was very important for us to have this information to help with the advocacy to bring resources to this community and to the Peel region, and to dispel some myths about South Asians and vaccine hesitancy, as well in our determinants of vaccine confidence or hesitancy. We do see some socio-demographic determinants. They do need to be confirmed when we've included the whole study, but I think may lead to some important areas to address in future epidemics or pandemics or other vaccination campaigns, in particular, individuals with lower level of education and new immigrants may need some additional communication and interactions. So I will stop there. If we go to the last slide, I would also like to thank our funders, so the Public Health Agency of Canada, CITF, our home institutions, and this large team. Many people contributed a lot of hours, and we also had a great, robust student volunteer group making phone calls, etc. And I would thank the South Asian COVID Task Force as well as the South Asian Health Network as our two South Asian advocacy partners. So I'll stop there and look forward to the questions. Thank you.
Thank you very much, Sonia. So your last little statement there really said a lot. You were talking about trusted sources of information and also engaging with advocacy networks. I just want to speak a little bit about some of the lessons that we can hear from what the presentations have been saying. So we have, let me just see, you can see me there, okay. Partnering with communities to tailor programs to their social, cultural, economic realities is really key if we're going to be able to reduce excess risk of infection and disease. Co-creating custom materials and guidance that address the concerns that people have about tests that would increase study participation, and also start the conversation about vaccines. Fostering sustained relationships and interaction between researchers and community members. This is not just a one-off thing. Longer relationships are very, very important. And addressing the upstream determinants, this is a broad agenda for us all to be thinking about to mitigate the barriers to healthcare, to housing, to education, and to employment opportunities. Next slide, please. So if we're going to improve vaccine coverage and uptake with at-risk communities, we're going to have to collaborate with community leaders and key opinion leaders to co-develop strategies to identify the issues and address the concerns. As Sonia highlighted, partnering with community advocacy groups to disseminate tailored information effectively is really key. And providing information about vaccines in people's own language and in accessible formats is absolutely baseline important. Next slide, please. So we're going to move to questions now. We've had a lot of questions come in, so we'll try to answer as many as we can. We're going to start, I think, going to bring all of our participants together. Thank you. And just a question for those of you who had to recruit for your studies. In brief, what recruitment strategies and approaches did you take for your surveys? And did you work with trusted community agencies? We heard from Dr. Anand that she did. How about Toronto and Montreal? How about you?
Yeah, I mean, I don't know if I should jump in, but our initial impetus in the study was to consult with the trusted community agencies in Montreal North. We did proceed to consult with about 8 or 10 of them, and we had good cooperation from them at the outset. There was a lot of reticence when they went through the organizations on the part of some of their membership and constituencies to take the dry blood spots. You know, we were actually a bit surprised by that, although we worked hard to at least get a beginning critical mass of respondents in Montreal North, which was our target area. And then from there, we worked to expand to the rest of Montreal to have a comparable sample. So Simone, I don't know if you want to add to that, but.
Yeah, in Toronto, we, as I alluded to, we really relied heavily on this community advisory group. But there was another aspect to the interaction. And in this regard, we partnered with existing organizations who were already plugged into the communities to allow for there to be that connection with us and to help to build trust. So, for example, the Black Physicians Association of Ontario, other groups with whom we connected. But a key point, though, and I mentioned this, and Kate, you alluded to this, is that it's an ongoing process, and we recognize that as we move forward, there's a necessity to modify things based on the nature of the work that is being that we want to pursue.
Thank you, Upton. Did any of you, this has been a question that's come in asking if any of you, not in these studies that you just presented, but in these relationships that you have with communities, if any of you are looking at post-COVID conditions in kids and adults and their interaction with social determinants? Sonia, go ahead.
Yeah, I was going to, I'll answer both, but just back to trusted partners, that was key for us to be able to move quickly and start to recruit. And, you know, there's so many delays in research. I know CITF tried to be as fast as they can from the application to get the money, but then we have our research ethics board approval. They also tried to accelerate things. But one challenge was to, once we had all the approvals and the funding, to get started. And for us, it was really key to already have had a relationship with a medical officer of health because South Asians have a high risk of diabetes and cardiovascular disease. And I've been working in Peel for probably 15 years. So because of that trusted relationship, they said, if you've got the RAB and the funding, we're going to open the door for you here. And when we tried to move into Toronto, also we had some connections, but that was more difficult. And we were hitting layers of people who had to approve things. I did reach out to our South Asian temple group because we've recruited for cardiovascular studies in the South Asian temples. They opened their doors. So I think those existing relationships were absolutely crucial for us. And with respect to the post-COVID condition, we have collected health card number. And there are now some codes to which we can link. So we will do this, but we are considering if we actually do a face-to-face assessment with our participants who answer yes to long-term symptoms.
Thank you, Sonia. Montreal or Toronto, anything on post-COVID conditions, long COVID?
Yeah, I'm happy to comment on that. You know, Kate, one of the things that we found in our work so far is that sometimes we, the researchers, would like to address a question, but then the community has a different thing that they want us to tackle. And so, for example, with post-COVID, what we have found is that people want to know, what is post-COVID? What should I look out for? How do I access care? And so our initial focus has been to try to work on the knowledge translation as this relates to getting people the information that they need to ensure that they access care. And so that's where we are at this point in time, because we think that there are some preliminary data that might suggest that in some racialized communities, the rates of post-COVID might be underestimated because of differential access to care. And so that's kind of where we're focused on at the moment.
Okay, thank you. There is a large Statistics Canada survey that's been looking at the prevalence of long COVID, so we should know more about that within the coming months. Sheila, we had some questions for you about, you used nucleocapsid protein antibodies, obviously, to see if people had infections. And there was a question that was asked about, given that vaccination can result in reduced levels of anti-N antibodies, do you think that this affected your results? And this question also had to do with, what proportion of your blood donor population is Caucasian? And are they more likely to have a reduced seroprevalence due to this issue?
Well, those are both quite good questions. So the first, relating to the nucleocapsid, this is really a question about how to interpret the signal that comes off of the analyzer. So, we get a nucleocapsid positive result or negative, and then we have to say, well, what does it mean? So with there are two reasons why you might not see a nucleocapsid positive when when someone has had an infection. And one is that they never got a nucleocapsid response. The other is that they did, and it was measurable, but then it waned. So we missed when we finally got to testing, to getting a sample and testing it, it was several months later and they're no longer positive. So our study doesn't really test for that. So we are assuming that when we see nucleocapsid, they were positive, and otherwise they were not infected. But what I can tell you about that is that we've seen the nucleocapsid rates rising over Omicron. We're now up to 73% of all of our donors as of mid-December. So that's, if there is a waning or a non-response, it's rather common for that not to be there. So it's most of the time you probably are getting a response from an infection. And then the other thing is that when we compared people who had just spike antibodies, so they're the vaccinated but not infected, with those who have both spike and nucleocapsid, the concentration of spike antibody is higher in those who have show evidence of infection. So I think we are probably capturing most of the infections. As we move along, and actually as the Secretariat, David Buckridge at the Secretariat is now doing, you need to take into account in your modeling the waning. So now, in relation to Caucasian versus racialized, we found that there was very little difference in vaccine uptake in our donors. So the racialized donors were maybe a little bit of a slower in uptake by maybe a month, but all of them got up to 100%. So it's probably not explaining the difference between racialized and Caucasian. We don't have data on who got vaccinated when, nor how many doses they had. So those factors could be important, and we haven't got that data yet. And there's the other question was what proportion are Caucasian. So in the donors, it's about 80% Caucasian and about 20% racialized. It depends on the age group. So our younger donors will have a higher proportion of racialized, more in line with the general population, and our older donors, those over 40 or so, are a little more likely to be white, but there's a mixture in all age groups.
Thanks, Sheila. Sonia, is that a legacy hand, or you want to come in?
It's a hand. I just wanted to make a point that was pointed out to me when I started my career by an anthropologist, that South Asians are actually Caucasian. So I would be classified as a brown Caucasian. So the best terminology is racialized versus white, or white European origin. So, but Caucasian is not equal to white European, because I'm classified as Caucasian.
Excellent clarification.
May I just add to that? We don't use Caucasian either in our question. So all of our donors, they either said they were white, or they listed their ethnicity, and they absolutely will give their ethnicity because it's so that we can match products to the right patients.
Yeah, thank you. That's a bit my error, because that's how the question was phrased. So, but thank you, Sonia, for clarifying. That was great. Upton.
Okay, I just wanted to echo what Dr. Bryan mentioned in terms of the nucleoprotein positivity and the loss of positivity over time. And we have evidence that has happened in the case of individuals who we know were PCR positive for SARS-CoV-2 and end up being NP not detectable. And so the rates that I gave you in terms of bordering around 70%, 73%, I really believe in our context represents an underestimate. So there's a fudge factor that needs to be added to that to take into account the loss of a nuclear protein or the absence of initial generation of nuclear protein positivity. What that factor is, I think we're still not quite clear.
Thank you, Upton. So this question that's come in, that's for all of you. It's sort of, how can we be better positioned to respond to COVID-19 for what the questioner is calling equity deserving populations, both information during the preparedness stage, the response, the recovery. What do we need to be doing differently? Anybody can start off with this one.
I don't know that in terms of doing something differently that I can necessarily make a positive contribution, but I will say there is something we need to do, I think, collectively. And I'd say this in support of my colleagues, Dr. Allen and Dr. Anand as well. We need to be able to do intersectional work. So by intersectional, I mean, we need to look when we do the sociodemographics of the relationship between the identity markers on the one hand and the sort of unpacking of those demographics, the relationships between age cohort and occupational status or gender or income. Now, our sample sizes don't necessarily make that an easy task. In fact, they probably make it a daunting challenge, but we need to expand further in terms of the work we're doing and push the sample forward so we can do some of the intersectional work. Because otherwise we're sort of getting a snapshot, and that snapshot may not take into sufficient consideration, some of those socio-demographics and those social determinants that arise from the demographics that we need to be able to explore more fully. Otherwise, those snapshots become sort of the profiles of those particular groups, which are fantastic, and we're seeing fantastic stuff. But if we could push it to that next level, it would really help us in terms of providing more sort of recommendations and suggestions for how to deal with some of the variations that we're seeing.
Thank you, Jack. Sonia, and then Sheila.
Yes, I think in terms of what could we do differently or how could we be better prepared, we saw throughout the pandemic that advocacy played a crucial role in making things happen. And so we might think that the federal and provincial and municipal governments can manage everything, or public health can manage everything. But we saw that there were gaps, and those gaps were eventually filled by advocacy groups, and we overcame many problems. If you live in Southwestern Ontario, you listen to radio shows, you would hear different physicians, sometimes medical students, speaking out saying our essential workers aren't getting tested, there isn't sick pay. It was a constant dialogue brought up by many advocates. So I think if we had a perfect world with excellent government officials, public health officials being connected into vulnerable communities, we may not need advocacy, but we really saw we needed advocacy, and to move fast, we needed trust with the communities. And those trusting relationships are out there. We just need to tap into them.
Thank you, Sonia. Sheila, and then Upton, and then we'll have to close. Sheila?
I think that we need to have a more consolidated approach to our data so that data from one community can help to feed into understanding about other communities. It has been, to some degree, different studies working on their own and then sharing the results at the end. So, but I think that we would have a much better response if we had platforms and methods worked out in advance, which, COVID came very quickly. We didn't have time to do all these things, but to be able to really bring it all together and to consolidate.
Thank you. And Upton?
Yeah, I think, Kate, in my mind, it's all about ensuring that we collect the data. We have the information, as Sheila's alluded to. And the process of collecting the data, it can be complicated at the start, but we really do need the data, and we need communities to be able to trust that the data will be used appropriately. And so there's that trust element that is absolutely essential. But there's one other thing, Kate, that we need to be able to do. We need to be able to identify low-hanging fruits of situations that require a response, to show the communities that the data being generated and we're responding to bring about change. And I think that that is really important, because collecting the data, that's not, it's not enough. We really do need to identify some low-hanging fruits and respond to them.
And that speaks in favor of co-creating and co-design and answering questions the community also wants answered. So working together. So I want to thank you. This has been another round of very interesting results and a great exchange with all of you and our audience. Unfortunately, I have to use the time that's remaining for a few brief announcements. First, I want to thank all of our presenters today, Dr. Sheila O'Brien, Dr. Upton Allen, Dr. Jack Jedwab, Dr. Simona Bignami, and Dr. Sonia Nam. So thank you all for your research and your expertise and your time today. And I'd of course like to thank all of our attendees as well. Thank you for sharing your time with us today, and I hope you enjoyed the seminar. So the CIF team will be preparing a summary of this seminar, and we'll make it available as usual on the CITF website. The team will post a recording of the seminar in the coming days, and the presentation, it's already on the website as a PDF in case you'd like to see it again or share it with other people. If you receive our weekly newsletter, you will be informed as to when everything is up on the page. And if you don't receive our newsletter and you'd like to, please go to the CITF website's homepage and sign up at the bottom. The CITF's next Research Results and Implications seminar, number 13, will focus on pediatrics and will be in late March. Please stay tuned for more information. Again, you'll find the details in the CITF newsletter, on our website, and on our social media pages. Here are the ways to get in touch with the CITF or to stay abreast of our news. I encourage all of you to follow us on social media as well. That's all for today. Thanks again for joining us. Take care and goodbye.